My name is Bill Herndon. I'm the Associate Vice President for the Division of Agriculture, Forestry, and Veterinary Medicine. I have been introduced to Dr. Henderson several months ago when they had a Mississippi Telehealth Association meeting in Jackson. And it really lit a fire in me. I thought there was tremendous potential after she described what they were doing and what they're trying to accomplish for opportunities for collaboration and partnership, not only with her, but with University Medical Center as well. And as it turned out, we do have plenty of opportunities. Rachel Jones is with her, and she is sort of the Marty Fuller of UMC, excuse me. And really are there. We've already identified a number of different opportunities for us to work together. And as a result of that introduction to Dr. Henderson and the things that she's doing, Chip Templeton invited me to participate in that, and we've talked a number of different times together, and it's expanded with a lot more scientists, a lot more people interested in this, in these opportunities to collaborate. So Chip has been working with Kristi for several years now, and Chip, I think, has the title, he's an Extension Associate for the Extension Service here, works with Dr. David Byes, where I think he stepped out just a second ago, and I think he has dubbed himself as the Mississippi Telehealth Liaison, or something along that line. But those are his connections to Dr. Henderson, and since he's known and worked with her for a number of years, I'm going to allow him to introduce Dr. Henderson. Jim?
Thank you so much. Okay, thanks everybody. I'm going to try to make this quick because I want you to really benefit by every minute Kristi's got to share with you today. I have a nice, her bio, but I think I'm just going to pick off the cuff for just a minute and tell you a little bit about it. I met Kristi about 3 years ago, and she's going to shoot me for this, but this is the way I think. There's not too many times in someone's lifetime someone really special comes along and has a vision for things that can really make a difference in our society. And I want you to know Kristi, Dr. Henderson, is one of those people. She's quietly gone about in a very unselfish way to presenting an idea 13 years ago, which has now come to a point that she's going to share with us today, kind of what's going on. But it has the potential to really change our society. Dr. Wynn Jones, back there in the back, who's a very good close friend of mine, and one of the, I'll call him founders of this place, has been kind enough. We have breakfast together several times a week because we've been friends forever. And that's sort of been the idea of coming here and maybe have CBU maybe to connect. Certainly not my place to tell you there's connections in life, it's just to try to make possibilities possibly happen. So before I introduce Kristi, I've never done this before, but I just thought of an idea. If I were going to write a one little square cartoon on Kristi, you can imagine it's this lake in the background, and it's Kristi in the foreground with the cane pole on her shoulder. And it's all the fish saying they've heard so many great things about it, they want to be in the frying pan. And they're all racing to jump and be on her hook. That's a good description. So, Dr. Kristi Henderson, welcome.
Thank you all for having me. Chip, I am going to kill you. And I've never heard that description of me, ever. So thank you very much. And thank you all for hosting me here. Okay, so I have a PowerPoint. I'm extremely passionate about this, as he just said. So I really love questions. I love you to try to throw me off guard, too. My clinical background is emergency medicine, so I like change and chaos. So I'm good with you throwing something at me and messing up my whole order of my presentation. So, but I really want this to be meaningful and have a personal piece to this for you, because this is going to impact every one of you, because healthcare is not going to be the same in 5 years. In 10 years, it's changing so fast. And so I'm going to give you a little snapshot of what this looks like, how we're using it, and what it means for for the country and even international. And then we'll kind of talk a little bit about what that could mean at Mississippi State and why it's important for you as an individual and for you here in this at Mississippi State. So the healthcare system is broken. If you haven't been to the healthcare system lately and gone to a clinic or a hospital or visited a loved one in the nursing home, which I would probably guess is none of you. Probably everyone has done that recently, and it is a nightmare. It's difficult to navigate. You go to a waiting room, you sit there, you probably got an appointment when you really didn't want it anyway, and that's not when they see you. If you go visit somebody in the hospital, you don't know what's going on. There's all these people coming in and out, and you're scared, and the patient doesn't know what's going on or what to expect. And everyone's trying to do a lot of good things and coordinate care, but somehow it doesn't come together, and there's not one captain of the ship that's really organizing that. And so it's fragmented, and the result of that is that people are in the hospital longer, or they're sent home and then they come back into the hospital because their illness wasn't controlled. And then people are dealing with chronic disease. 1 in every 2 of us in this room, so 50% of all Mississippians have a chronic disease. That's a national average. I tell you, in some parts of our state, it's closer to 80%. And it's not just one chronic disease, it's often diabetes, high blood pressure, heart failure. And so we expect people to be able to control their disease by coming to the doctor once, maybe twice or 3 times a year. But the majority of their life is trying to manage it on a day-to-day basis. So I'm going to speak a little bit about how technology is sharing our resources throughout the state, but also helping people on a daily basis manage their health, because the possibilities are vast. And so when you start talking about the money that's spent nationally on health care, we don't have a proportionate return on that investment. We have one of the highest budgets on health care, yet our health outcomes don't match that. And we continue to have this problem. It's a system we can't sustain. So if we keep trying to open more clinics, hire more doctors, train more nurses, whatever it may be, we're still just barely trying to keep status quo. And so we still have lots of our state in particular that doesn't have access to care. And I'll speak a little bit more about that in a little bit, how much time is spent traveling to get access to health care. It takes, on average, 21 days for somebody to get in to see their health care provider. And that's if you've got an established health care provider, and you've got insurance, and you've got the copay, and you've got transportation. It's just the reality is that this isn't easy for somebody to be healthy. And so the healthcare system is creating an environment that is making it difficult for us to make a difference. And we've been at the bottom. We teeter between us and New Mexico being 50th in outcomes in the country. And so we've got to do something different to change things. So I'm going to tell you a couple stories because I like to make this personal. And these are all real stories that happen here in Mississippi through our telehealth program. So I'm going to kind of tell you a story about how we use telehealth, and then I'm going to go into exactly what telehealth is. So this is TJ. TJ is actually in a southern county, Perry County, and with permission, all these people are shown. So because this program has saved their lives and changed their future. But him and his brother were playing hunting, and he was accidentally shot in the chest. And so they were out in the middle of nowhere, put him in his truck, and they're calling the ambulance, and they meet at a convenience store, and the ambulance takes him to the nearest emergency room. And that's how communities work. So they get to the emergency room, and most community hospitals, the ones all around here, not Octava Hall here in this Starkville, but all your surrounding areas, Winston County, which a hospital that just got destroyed by a hurricane, a tornado, but all these communities and counties around our state have small community hospitals that have at night, and most of the day, maybe one physician or nurse practitioner staffing the whole place. So there are no specialists. You come into an ER and you have somebody to try to help save your life. So this child is brought into the ER. This could be any of our children. Is brought into the ER. There's not a trauma surgeon. There's not a cardiologist. There's not a surgeon. There is not one in that hospital, and there's not one living in the county. And so what you hear people talk about is they just kind of Band-Aid station and ship people out. But the problem is the time when you can have life-saving intervention is that first hour. And so you spent that shipping people around, and I'm telling you the outcomes are not what they should be. So when he was brought in, none of those people were on duty there, nobody in the county, but there was a nurse practitioner working in the ER. And normally, he would have died. And matter of fact, his heart stopped 3 different times, and they brought him back to life 3 different times. He ended up living, though, because of our telehealth program. So while they didn't have a physical trauma surgeon and emergency physician there, we were connected to University Medical Center with this place, and they were all there virtually. So they were guiding the care, they were preparing the OR at their facility, they were doing everything to make his chances of survival better. And I'm telling you, he would have died. His mother tells the story, and I have a video of the story. It will stop your heart. And he was flown to Hattiesburg, had 1 surgery there, stabilized, and then flown to university. And now he is healthy and happy and running around, other than the scar down his chest. So this is where a system would have failed him. He would not have lived, because where you live does determine your level of health care, period. There is a geographic disparity in health care. And there's nothing we can do about that. I can't recruit and retain people to small towns of 500, 2,000. You just can't support a physician there. This is Jackie. Jackie's in the Mississippi Delta. And you know, it's interesting. The Mississippi Delta is studied all the time. Every person in another state decides they want to study the people that live in the Mississippi Delta because they're the most unhealthy, they have the worst poverty, health literacy, and all that. Well, so I love talking to Jackie, because Jackie will tell me the story of, I've been in every program there was. Everybody brought something in to control my diabetes. They were going to get me well. And I knew I was supposed to eat right, take my medicine, and exercise. That wasn't the problem. I didn't want to do any of that stuff. Family members had died from it. Family members had had amputations from diabetes, but no one had gotten her disease under control. Because it's about a lifestyle change, and that's the hard part. You know, we're all good at a diet from January 1st to January 14th. After that, the shiny object isn't so fun anymore. So we put a tablet into her home. So I have an electronic tablet in her home. She goes about her normal life. When she does her finger stick glucose every day, I see what the results are. So my team at UMC is monitoring her on a daily basis and interacting with her. And she answers questions about her medicine and her life or whatever. And we can intervene at the time something's going wrong before we wait until she has a clinic appointment at 6 months to say, oh, that whole time your glucose was elevated and we should have had you on a different dose. Meanwhile, it's damaging heart, kidneys, eyes, everything else. So we have a tablet, electronic tablet, that we give her. It's at home with her, and we work with a telecommunication company so we can video into her, we can talk to her, we monitor her glucose, and then we have this little neat part about it that's really health coaching. And it's a support group. And so Jackie knows all of us, and she knows. She calls us her police, because she knows on the highway, she knows what speed limit she's supposed to go. But if there's not a cop around, she's going. And so she considers this. She says, I know that my nurse, Cindy, is going to be watching me. I know if my sugar's 300 this afternoon, she's going to call me and say, are you out of your medicines? What did you eat? Let's talk about this. So you intervene and you give people support in life. And so it's a virtual support group and care coordination. But we're doing this with their community doctors. So their family doctors aren't pulled out of the loop. We're letting them go there, and then we bring in all of our specialty resources like an endocrinologist, ophthalmologist, pharmacist, all those people that normally you'd never get unless you came into an academic medical center. We're bringing that into the Mississippi Delta, to this small family practice clinic. So when she is at home, we're monitoring her. When she goes to her checkup at her regular doctor's clinic, we're also videoed in with our specialists. So the team all works together, and we help that family physician work with complicated cases of diabetes, hypertension, whatever it may be. And now her disease is under control, and all I hear from her is, please don't take my tablet away. So she's loving it, and the neat part, you'll have to watch, PBS has just filmed a documentary on this program because of the success of it, and they're airing it in April on an hour-and-a-half, it's an hour-and-a-half program focused on innovative approaches to healthcare. And my favorite part is that when they came down, the film crew came down, they took them not only to their home but to church. And the pastor, of course, stops the whole sermon and introduces this film crew to everybody. Now they're all family and friends. But so the New York film crew got a flavor of Mississippi Delta and people that are really telling the story of why we haven't been able to control their health to this point. And so this is really about personalized healthcare and using technology to do it where people are and when they need it, instead of expecting people to change their lives and come get it. And we really have demanded that in every other area of our life. Why not healthcare? So this is Chris, and he drives 2 hours to work every day. Works up in Columbus, and so the reality is that he doesn't get healthcare, because if he takes off from work, he's not paid. And so when he gets off work, everything's closed. And his doctor's back in his hometown, so he has to drive there. So it's not only is it closed, he'd only have the ER to use, so he just doesn't get health care. We now put telehealth into the workplace. And so all the employees there have access during breaks, during lunch, before and after work, to see us for primary care needs, urgent care needs. It may be something as simple as, their sinus infection or the flu or a cough, cold, rash, pink eye, whatever it may be. But the reality is we catch these things early, and at that time, not only do we help them with the immediate need, but we start linking them in to get that other care that they need for their wellness and checkups. And so we're bringing them an immediate result, but they also then understand and benefit from the health education. And so we started this program putting technology and telehealth clinics into businesses out of a request starting last year. And we've got, I think, 9 on now, 4 coming on next month, and it's just making a huge difference in cost. The cost of this is less than most people's copay. And so it's not only lower cost, but increased compliance and improving their health. So now at the businesses, they're saying, okay, I'm getting more productivity. They're not taking off a half a day to go to the clinic to get exposed to something else in the waiting room. And then, so it's just a snowball effect and unintended benefits from a program that was around just trying to make people have access to health care where they needed it. So those are 3 different stories that in our traditional model, it would have been a child that came into an ER and died from a gunshot wound. It would have been a lady who eventually would have had the complications of diabetes that ended her life early. And we'll have a generational impact with her as well, because children and everything else, it's a big impact on the whole family. And then, of course, in the workplace, we have people now getting health care, so businesses are thriving, and it's a huge impact to the economy of an area. But having a healthy workforce and a healthy community has multiple different economic benefits. So let me tell you exactly how this works. So we did start this 13 years ago. I won't even talk about the years before that of having to debate with regulatory and licensure boards and all the different people that weren't sure if we should try something like this. It was too scary, it was not the model, and policies were written based on our traditional model. So we were in violation of a lot of policies, so we had to clear all those barriers, and that took us about 3 years before we could even start. So it's really about putting healthcare where people need it, when they need it. And so we started it around emergency medicine, and it was because I was running the ER at UMC, and we were getting patients transferred to us that were not having good outcomes, and the communities were having problems keeping their hospitals open. So the economic stability of a small community hospital is dependent on patients getting admitted to that hospital. Most hospitals admit patients, almost all of them, from their ER. So if your ER doesn't work, you aren't going to have patients in your hospital, and then the hospital is going to have to close. And if a hospital closes in a community, you know what it means for business, education, and all other pieces to that. So we started this all around emergency medicine. We started putting technology so that whoever was working in that ER could be connected to all of our specialists and our ER physicians, and would help stabilize and keep people in the community. And when we first started, people were like, oh, you're just going to try to transfer everybody to UMC. This is just for UMC. So we started slow and methodically, and what we found was they lowered their cost of staffing their ER 25% and increased their admissions to their hospital 20%. So they were winning. They were saving money, admitting more people, and their hospitals were thriving. Not that we want people in the hospital, but these people needed to be in a hospital, and it's better to support the community than have them all come to UMC when they didn't need to be there. Some do need to be, but not all the ones that were being transferred to us. So we use the technology. It's a two-way audio and video technology, and in every situation, the technology we use is based on whatever clinical services we're going to deliver. So I'll give you a picture. So this on the right is what's in the wayside. We often use what we call a telemedicine cart. And that's because we can roll it from room to room, take it up to the first floor, wherever we need to. So the cost to a hospital is very small when you're talking about one device that can do it all. And then we, on our end, have a control center, which is the on the left, and we have somebody dedicated sitting there waiting for these calls all day long and responsible for all the acute consults. And they, on this side, are the ones that control the camera. So you don't have to do anything. The person, the nurse, or the doctor that's at the way where the patient is, they just take care of the patient. And then over their shoulder is this camera that's zooming in and being controlled by our folks at UMC. And we can connect into their radiology system, to their lab system, to their electronic medical record, so that we can help process what needs to be taking place for this patient and then transfer them as we need. So I won't stop with that, because I'll tell you the technology allows, I think I have a picture of that in a minute, but things as simple as this is an otoscope. This plugs in with a USB device to any laptop, desktop, and to my telemedicine cards. So I can see actually in the ear better than in person, because I can then, it's on a screen, and I can blow it up, change the resolution, change anything about it so I can see better. So we have devices and scopes like this, and a stethoscope that's Bluetooth, so that when the person with the patient puts it on the patient's heart, it's broadcast over to my physician so they can hear heart and lungs just as if they were in the room. And not only is it a good teaching tool, but it's a very good diagnostic tool. So we're not lowering the standard of care and cutting corners and guessing. We're doing the same exam, we're just using technology to do it and broadcast it remotely. So it's really just about bringing healthcare to patients. And on our side, our providers, our physicians, our nurses, our psychiatrists, all the different people that we have using the system, they have different devices. Some of them use an iPad, some use a laptop or a desktop. It's very mobile. I had to know that not only do I need to be convenient for where the patient is, but I needed my team to be used very efficiently. So if it was a burden to my doctors, they weren't going to do it either. So now we have most of them in their laptop, in their pocket of their lab coat is their iPad. And with one button, they connect in, and they can connect to a patient anywhere in the state where we have a telehealth access point that has this equipment. They can talk to them and interact with them and assess them and provide treatment. So when you think about things like stroke and how hard it is to find a stroke neurologist in the state, there's very few that take call, and there's not enough of them to manage all the stroke in the state. But now, if I have, even if they're all concentrated in Jackson, Tupelo, and Gulfport, Hattiesburg, I now can have them cover every county, and so that you in Oktibbeha can have the same level of expertise as somebody that lives in Jackson. And those resources now become available because they're mobile, and these physicians can be covered anywhere. So we're using a lot of technology. You've probably heard of everybody talking about these electronic medical records and meaningful use and all that good stuff. And for those that aren't in healthcare, this is really guiding and driving how we're documenting care and how we're sharing information. And the whole goal is, and they call it meaningful use because we're supposed to share it so that people don't duplicate work and people have an accurate picture of the health of each of us when we go into the healthcare system. And we think that's one part of it, but there's a lot of how we can use technology. So I talked about consults where we have our specialists and any of our providers that can use the system to be available to you in your community or anybody. The remote monitoring was the story of Jackie. So anybody with a chronic disease, I can support them and monitor their health on a daily basis. So I send home scales, blood pressure cuffs. I can do anything vital signs that you have checked into the clinic, we can check at home, and then we can do video as well. Some of the neat technology that's moving forward is even around medication management. One of the biggest reasons we don't have good compliance of chronic disease is people don't take their medicines. And if you think about it, it's for a lot of reasons. One, they get confused, especially if you start getting into elderly when they have a pill box that it would take you an hour to figure out what you're supposed to take, and if it gets mixed up, what do you do? So there's these new devices, the box is connected to my system. So I know if you're supposed to take that blue pill at 3 o'clock and at 4 o'clock it's still in there because you didn't open it, it's going to alert at the home and alert me so I can call you and see what's going on. Well, Big Brother, I understand, but the reality is that some people need that added help to support them and help them understand why it's important and remind them that they need to take it. When you think of mental health, elderly, those are two populations where there needs to be extra support and medication management. So there's everything from pill bottles, your standard pill bottle that your medicines would come in that have computer sensors on them, and they blink and they make noise and they do all kinds of things, and then they can communicate to my center so my nurses and case managers can call and help try to figure out what's wrong. And a lot of times they ran out of their medicine, they were having a side effect, and that's an opportunity for us to teach, for us to find resources for them and intervene before they're in the ER. Personalized health, this is going to be a lot of fun. This is still very new for everybody, but you see everybody run around with Fitbits and all the different devices that are monitoring your steps and your sleep and your eating and your whatever, all it's doing. That ties into the same system. So the challenge is going to be moving forward, how much information is too much, and who's going to look at all of this and do something with it. And so our strategy is one that we're going to have our care team trending the information and looking for outliers, so that based on protocol, I don't care if Kristi has walked 10,000 steps every day. I care if all of a sudden there's a day where there's no steps. Did I fall? Am I sick? And so there's a lot of significance and deviations from the normal. And so we're building the protocols, and this is where this whole predictive analytics that's on the next bullet point is going to come into play. Building a system that will mine the information from the pharmacy, from your insurance company, from the electronic medical record to say, Kristi's at high risk, and we can have a high impact if we'll monitor these things. And so it does a predictive part of it for me to risk stratify and say, this group of people I can be proactive and do something for. And then it'll classify those that, you know, maybe it's just preventive and wellness. And maybe I just send you a text that says, hey, this is your year for your colonoscopy, don't forget. And little reminders. All kinds of things we can do through pregnancies as well. So how do we use the technology that people have in their lives every day? Everybody has their phone and they can't let go of it. How can I communicate and use that to benefit their health and use it in a meaningful way? And balance in-person care and telehealth care so that it's a high touch as well as a high tech care that isn't too Big Brother. There's a balance in all that, and it's going to be different for everybody what that means. And so that's going to be the fun part building this. And then population health. And this is a buzzword you hear everywhere now, and everybody defines it a little different. But we're looking at it, doing the analytics to be able to stratify. So Mississippi in a whole, what is the analytics of our population? Who's at risk? Where do we need to intervene and to what level? And there'll be tiers of our intervention. It may be that you're healthy, not at risk, don't have a family history that concerns us, and we'll just send you text messages or whatever, however you want to receive it, information about health and wellness and help support you being well. Then all the way to the level of, you know they have a chronic disease and we're going to give them devices in the home to monitor them and help them be able to manage their disease and stay healthier and prevent it progressing to where they're in the hospital. So there's different levels of this, looking at it in communities and whole populations. And we are looking at it, we've started a lot of work in the Delta, but we're going to do it for our own patients. We're now having insurance companies asking us to do it for all their members. So if you're able to do this, they want to keep their beneficiaries healthy and keep the cost down. So they're looking at it as a whole. Can you manage all of our patients in the home? And then this analytics, all the same stuff applies. But a lot of possibilities of where we can go for that. And across the country, you hear some big health systems doing some good work with that. VA is doing a lot of good work as well. But we are one of the leaders in this as well. And we're still very early in it, but we have a lot of possibilities of the next steps. So this all is possible because I have a telehealth call center, and it runs for 24 hours. It's open every single day, and I have clinical as well as technology folks there all the time. And every phone call that comes in, whether it's for an immediate consult with a stroke neurologist or emergency physician, they handle all that. They immediately push it to the device of whoever's on call for that service and manage all that complicated scheduling. Then we have patients that may live here in Starkville and they may need a psychiatrist or a cardiologist or a child development specialist for their child who has attention deficit hyperactivity disorder. Whatever it may be, we can schedule appointments so that you can go into your regular clinic, and then we bring our specialist in as a part of the team to help take care of you and avoiding you having to drive to go get that service. Now, there are times you're going to have to drive, but we're going to minimize that, and it may be that you come for one and then all your follow-ups done back in your community. If you think about the burden it is to take off from work, find transportation, people to watch your children or help with whatever issues, your dogs, whatever. It's a burden to have to drive 2 hours to go get health care, not to mention find parking at UMC. So we run a 24-hour call center. It's actually not on campus at UMC. It's in a separate building. We grew out of our space, and we're excited to announce on February 24th we're going to have a groundbreaking of our new building, so you'll have to all come and see that. Around our Center for Telehealth and Innovation. So the possibilities there are endless. So let me give you another little picture of what this looks like. So we bring the health care to you, but if you were in your office and we provided health care to all the employees, faculty, and staff here, on their phone, on their desktop computer, whatever it may be, with one click on the UMC icon, it pops you into what we consider a virtual waiting room. So you're now in your own space, and my team is watching the waiting room. And they grab you out, they register you in the system, they get your history just like you would give in a regular traditional clinic visit, and then they do your exam. And this is all done in your own virtual exam room, and you never left your desk at your office. And we provide that. Then if we have to give a prescription, that goes to your pharmacy of choice here in town, wherever it may need to be. That's your decision. You can electronically prescribe that, and you then, when you get off work or out of class, you run by the pharmacy and pick that up, saving time and money. Here's an image of what that looks like. There's a healthcare need, appointment scheduled. It's done. Our providers, this is one of them, interacts. This is actually a business that's showing on the screen. And they interact and talk, and that whole assessment's done. It's documented just like if you were in a traditional clinic, so that if you can get copies of your medical records, your primary care provider can get a duplicate version of it as well. I mentioned that the diagnostics are pretty impressive. This is the images of someone using the exact device I have, where they can see the eardrum. The top is doing a stroke exam in an emergency room, and then you can see the ophthalmology exam. It's quite phenomenal what you can see and what you can do through the technology. And the good part is the cost of all this is coming down dramatically, so that this is actually something I can roll out and sustain. So while I'm a part of UMC and part of a state-funded academic medical center, we don't take any state appropriations. And so we've managed to build this program very slowly over 13 years on partnerships. And so the expense of this has been shared over all the groups of people. 165 non-affiliated sites around the state are helping cover the cost of this. So this is not a state appropriated or grant dependent program. We love grants and I apply for them all the time, but it's not dependent on that, and we use that a lot for testing and new pilots and seed money. Here's some more examples of what the technology looks like. All kinds of options, from little mobile devices, your phone. The phones these days now, you can click in all kinds of devices to your phone. You can even do loud on your phone. We're not doing that yet, you can. You can do echocardiograms on your phone. You can do EKGs on your phone for heart tracings. You can do, there's breathalyzers that pop into the phones where they're working on where it'll eventually go to where you breathe in it and they give you a diagnosis. We're not there yet, but the research and development arm of this, the possibilities with an infrastructure like we have people and startup companies want to come and bring this technology in and say, let's test this. Will you be a beta site? You've got such a solid telehealth infrastructure. Let us work with you to find all the gaps. And so we're working with many vendors to be able to help find a better solution for what we need. And I always tell them, quit testing all your technology up in the Northeast on the skinny white folk men. Come to Mississippi and test it on the real people. So, and it actually does work when I tell them that. But there's a lot of benefit for them to be able to test it in a real environment. Here's a picture of what our electronic tablet looks like that we've been sending home. Our next version is actually the iPad, so it's a little bit smaller. We do lock them down so that they only are used for this program. They can't play on them and watch all the videos and all that good stuff. So that minimizes the likelihood that they're stolen or sold or whatever else. But it really is around health coaching, encouragement, and living their life with them and holding their hand through the process. The whole goal here is not to do this forever. It's to come in and be a lifeline and a support until we empower them to take this over and manage their own disease. People will come on and off of this. They'll come in the hospital and we'll need to support them for a little while. Then they'll come back off. And so we'll have the ability to come on and off and not be any more intrusive than we need to be to manage their disease. On my end, what makes this all possible is that I have a dashboard that my care team monitors. And so I talked about the analytics. If they were going to have to go into a website and look up every patient every morning to find out what was going on, I would have to hire everybody in Mississippi to do this. So now I can manage large volumes of people because it does the work for me and pulls out of all the people I'm monitoring. These 4 up here at the top are the ones, or 5, are the ones that we need to manage and call and intervene on right now. The yellow, there might be an issue, let's watch them. And then the green. So it does that analytics and risk stratification so that I can know what their risk is for admission or deterioration of their condition. And then we can hover over any of that and find out what's going on to be able to intervene very quickly and manage a large number of people. So then you're starting to look at ability to cover large numbers of people in our state with a centralized monitoring station working with the community and social workers and case managers at the local level to be able to help manage their disease. So we're really looking at using a whole picture to this, looking at everything that has a piece of the information that we need to know how healthy somebody is. Having one electronic medical record isn't enough. I need to know, did they fill their prescription, or even more importantly, did they not fill their prescription? So there's all this information that we're slowly pulling together through a health information network to be able to put into our dashboard to help us know, along with wearables and along with the devices in the home, what's the snapshot right now where I can do something to actually change their health. And so it's really taken it to me. And one of the challenges people have all over the country is, okay, this is all great, but who's looking at this information? Your physicians are very busy and they don't have time a lot of times to review all the records before they come see you in the room in the clinic. And so what we're doing is using the analytics to help with that, and our team to be able to trend that and only notify the physicians and nurse practitioners on the information that's actionable and meaningful to them. And so we summarize it, we put that there, we communicate with them so that it's a good use of their time. So we're doing some pretty cool stuff, and I will tell you that in Mississippi we are connected to these 165 sites. I think I've got a slide here. 165 telehealth sites around the state, and those are what I'm considering telehealth access points. We deliver 35 different medical specialties. And we built this on community partnerships. So I didn't start a program without having a customer that had asked for it. So a customer from a community calls and says, I need genetic services or whatever it may be. I need patient navigators or physical therapists, and I don't have enough of them. Can you help? And then we build a program, and then inevitably there's more and more around the state that need the same thing. So we're building a customized, individualized program for each center and each community so that we don't take away and hurt the community, but that we enhance it and just fill gaps in care. One of our biggest concerns was we didn't want to look like UMC the Giant coming in to take over. We want the physicians that have chosen to be in rural areas to stay there and us to be a lifeline and to support them only where they need us to, but to start turning around the health of our citizens. And that really has been a strategy that has worked very well because they're winning and we're improving health. So we have, and I put over here, over 500,000 telehealth visits completed. And the reason it says estimate, because this drives me crazy, is that Before about 2000, whenever we went to electronic medical record, it was a manual log of all of our telehealth consults, and it wasn't perfect. We actually are probably somewhere around 750,000 now. We do know now everything's put in electronic medical record, and we're seeing right around 8,000 telehealth consults a month around just in Mississippi, so just right at nearly 100,000 a year. So the demand, I can't keep up with it. It is hospital, clinic, businesses, schools. You're lucky here at a college to have a health plan, but community colleges don't have that. So now we're helping community colleges. If you think about the elementary schools and preschools, there's not health care. Parents have to take off from work, child has to leave school, and it's often that, you know what it is, it's that darn pink hour, it's that whatever. And so not that they don't necessarily have to leave school, because there are contagious illnesses and they have to leave, but we can make everybody's life easier and be able to provide care quicker and with less cost. Here's where we are. Green are active right now. This map keeps changing almost every month. And on the left are the list of places where we're actually connected into. We do not go direct to consumer, meaning you couldn't call me and say, I want you to monitor my mother at home for heart failure. That is being done in some parts of the country, and we can go to that. We really want to support community clinics in the health system that already exists, so we're doing it in partnerships with companies and health systems around the state for that very reason. We're also in the prison, which I can tell you is saving our state millions. So if you think about every time all the prisoners, if they have heart failure or HIV or whatever, hypertension, they have to go to a doctor every 4 months or quarterly. So they go 4 times a year, 2 guards, all day, transportation, they leave, and then they go travel to get health care, and they come back. And they do that over and over, and millions of dollars goes into the health care of our prisoners, and now we flipped it, and we're bringing it to them, no guards, no transportation. They only leave when they need a procedure or a diagnostic test, and it's saving millions. So that's exciting. Here's a list of services that we're doing, everything from allergy and immunology to wound cough, wound care, toxicology, psychiatry, it goes on and on. If you get the care in person, we can do it over telehealth. So we also, this is some of our vision of where we're going, and I'm really looking at it as access points, so I'm looking at the whole state as a map to be able to say, do I have coverage? And can I say that every Mississippian can get access to every kind of service that they need within 5 minutes? And so if you start saying it's only 5 minutes away, usually people can find a ride to get there, or they can find public transportation. And so we're looking at it, mapping it with the Department of Health, with community clinics and hospitals, now going into nursing homes, assisted living, to be able to help support that area as well. And then my favorite is going into the homes. But again, that's in partnership with their primary care providers so that we can just monitor them in between. Okay, I won't be quick on these last ones because I don't have time for any questions. But so we started this for healthcare. And then we realized, well, wait a minute, we've got a great connection and people need education. So we then started partnering community colleges with community hospitals so that we could build workforce. So we would go in, and we actually have, I think it's now 6 medical coders that have graduated. They were janitors or patient clerks or whatever in the hospital, and they wanted a degree, but they couldn't get one. They didn't have time, so we brought the the education through our network to the conference room of the hospital and provided education. So on their lunch break, before work, after work, they took classes, and then they're graduating and getting a career. So it was more than just more than healthcare, it's education. And what's been the neat part is we're creating new jobs. And now when any company wants to come into Mississippi, they find out about our telehealth program to say, if you want to go to this community, they look at education, healthcare, and the workforce. That's immediately what a company does when they're trying to decide where they want to go. So they were looking at places that have 2 of the 3 and may not have good healthcare infrastructure. Now they find out, as soon as a company's looking at our state, they give them information on our telehealth program. We can bring it to you. So you've got that covered. Check that off the list. And once we start getting our workforce healthier, then we have even more opportunity for business development. So we have health deserts. We have a maldistribution of all of our clinical resources. and it's an inconvenient system, the traditional model is. And so telehealth is changing that and flipping that whole model. So we're known nationally. I'd say we're still in the top 3, maybe in the top 2 now, of telehealth programs in the country. And one of the things that really was a tipping point was the governor passed into law 2 years in a row reimbursement for telehealth. And what that means is that if you go to a clinic and see a doctor in person, your insurance pays a certain amount for that. Well, if I now do it over telehealth, they pay that same certain amount, exactly dollar for dollar. The reimbursement's the same for in-person care as telehealth. So now I have a model that's paid for, so the providers that deliver the care get paid if they provide it over telemedicine or in person. So we have a model that's really a tipping point. We have the broadest legislation on telehealth reimbursement in the country, and we were given an A rating by the American Telemedicine Association as a leader in that. We're now asked to go and testify in D.C. For federal legislation to change reimbursement from Medicare from CMS. So I just got back from there, and the interest is phenomenal from the Federal Communications Commission and from different congressmen around us sharing the Mississippi story of how we actually did do it. We actually did what we said, and we've been this kind of silent force building a program, and all of a sudden we turned around and we have better outcomes, we have better access to health care, and we did it with lower cost. And so we've strengthened the community in the meanwhile. So it's now like, wait a minute, I was just up there, and we had a big poster sign. I wish I could have brought a copy of this. And it said, this was in the Rayburn building in D.C., and it said, Mississippi, a leader in innovation, meeting the triple aims. And so the triple aim, if you don't know, is better health care at lower cost. That's a CMS initiative. And so it had Mississippi as a leader in meeting the triple aim. And people would come by and laugh and go, oh, I've never thought I'd see that. And I'm like, I'm from Mississippi, excuse me. So it's just really cool, a great opportunity for us to continue to build this and to capitalize on it so that every person in the state knows about it and can get access to what they need. Because we can probably use the technology they already have, which is their phone. We can even go through cable TV and connect into their house. So there's a lot of possibilities. So one day, U.S. healthcare system will be seen as the most efficient and effective. And that's really the vision of where we're trying to go. It's not just about Mississippi, but it's about creating a model here that others can use to replicate, and so that we can turn around our healthcare challenges. If I have 2 minutes, I'm going to show you a quick video. This is our corporate video, but this to me gives you a good picture of what this looks like.
Imagine healthcare right when you need it, right where you are. The University of Mississippi Medical Center is leading the state in bringing healthcare to patients. It's because of our telehealth program. Telehealth brings healthcare to people instead of people having to drive to get care. For over a decade, UMMC has been using digital technology to deliver health services to patients all over Mississippi, even hundreds of miles away. The success of our telehealth program led to the request for telehealth services to be delivered to employees in their workplace. Now Mississippi businesses can offer health care in the workplace. Did you know the average person visits a doctor's office for one of these urgent care needs at least 3 times in 1 year? Cold and flu symptoms, allergies, poison ivy, pink eye, respiratory infection, and sinus problems. So what are your options? First, you could call your local healthcare provider to make an appointment. But what if you can't get an appointment when you need it? And if you can, do you have the time to sit in a waiting room? Finally, there's a better option. With corporate telehealth, an illness can be treated in your workplace the day you need it. So you're probably wondering how exactly this works. The process is simple. UMMC has designated healthcare providers that are waiting and ready to see patients remotely through telehealth. They are known as our telehealth providers. When an employee has an urgent care need and would like to see a telehealth provider, the employee schedules the appointment online or calls our center for telehealth. The appointment can be scheduled for either the first available or at a specific time that meets the employee's needs. When the employee's appointment time comes, they simply log into the designated desktop computer in a private room in their workplace. Then they're immediately connected to our telehealth provider on the screen with two-way audio and visual connection. The patient and telehealth provider are able to discuss all health issues, and the telehealth provider is able to examine, review symptoms, and provide a treatment plan. If a prescription is needed, it can be sent to the employee's pharmacy of choice. The University of Mississippi Medical Center's corporate telehealth program is different from other telemedicine companies. We are connecting you to Mississippi's only academic medical center's team of healthcare experts. Our telehealth program is changing healthcare for Mississippians with a positive return on investment, seen through minimizing and work, keeping employees healthy, maximizing productivity, and decreasing the overall healthcare cost for both the employee and employer. Take advantage of your corporate telehealth program today and let us simplify healthcare for you.
Okay, so that's a good picture of what that looks like. It's that easy. Okay, questions? Questions? That's terrible.
What are the challenges? What are the challenges that you're facing now?
Lots. So it's not easy. The challenges are several things. Now that we've cleared all the barriers to reimbursement, things like that, now it's fair game for anybody in the country. And so other non-Mississippi-based businesses are seeing a nice business opportunity for them. And so they may be in California soliciting business of our patients in our state, which could take away from the success of our providers and the strength of our communities. My fear with that is a couple things. Mainly that patients would get harmed if they needed in-person care and they did a telehealth visit they needed. They're not going to know where to send them or what their options are around here because they don't know Mississippi. So we're working with the medical boards, Department of Health, and others to craft regulations that sets a minimum standard. We can't not allow competition in the state. That's all good. Come on, but we're better. And we want to make sure we're on the same playing field. A lot of those are even doing it without video. They're just doing phone medicine is what we call it, and taking payment. So it's really a mini insurance plan. They'll solicit you to say, for this amount of money, we'll cover you and your family for any time, anywhere. And they're mostly talking on the phone and prescribing. And so we're worried about outcomes with that. And we don't want ours to be labeled with a bad outcome when we do a different level of exam. So I would say that's a big challenge. And then just really now that everybody's excited about it in the state, to have somewhat of a consistent method to do this, because if multiple health systems are coming to a clinic and saying, don't you want our cardiologist, and then all of a sudden there's all this equipment in there, no one knows which one connects to which hospital, and it can get a little messy. So I would say that we've overcome the biggest challenges, but now it's just going to be smart about rolling it out in a safe way so that patient care is good and that we don't have any bad outcomes.
So I'm thinking of the specialist. Do you find that they are interested in doing the telehealth, or is it, it's that trade-off between staying in my narrow field or staying local and seeing patients in person? What do you find in there?
Both sides of the spectrum. It's interesting. I thought it'd be an age spread of who wanted to use technology to do this and who doesn't, but it's not the case. And I actually find that the more seasoned, experienced clinicians like the technology more so than the younger one. I think it's a confidence in their practice and their comfort level doing the exam is what I've decided, but that's my personal take on all this. And some of them physically can't run the hospital and their clinic, or maybe even disabled now, and I can still use their brain and mind and extend careers, which I think is very cool. So, I see it across the board. If they don't know, they don't like it. If they try, they usually say, oh, that's pretty cool. Most of them like to do both, some in person and some telemedicine. And I think that's probably the best way to do it. There's times you need to see somebody in person.
As Mississippi being the least broadband connected state with our rurality, how's that in your program? Is that an issue in your program?
It used to be a bigger issue, and I had to run a point-to-point telecommunication line to anywhere that had any significant telemedicine, and so I would do that. and manage that, pay for the line, the whole bit. Now, because people have had to upgrade for electronic medical records and the radiology systems, that's not the case. But I am working at a federal level with the Federal Communications Commission, and then all of our major players as far as telecommunication providers in the state. Routinely meet with them to say, okay, here's my roadmap, let's overlap our roadmap. So when you're laying new infrastructure, that we have a vision of where we want to go so that we can, because it helps them as well. So right now, the hospitals and clinics, good. Homes is where there's a challenge, but there's a lot of work to be able to improve that by several providers now. So it's a challenge, yes.
And doctors that you had to hire to manage this healthcare team?
So that's interesting. I started at the beginning where I had, because it was in emergency medicine, 14 of those physicians agreed to do telemedicine, and then I had some nurse practitioners to work with me as well. Then now we've decided there's such a demand, and this really is the way of the future, that every physician that's credentialed to work at our hospital is credentialed to do telemedicine for their specialty. So if they're a cardiologist for us, a part of their practice and how they serve their patients includes telemedicine. So it's really an institution commitment to that this is the way of the future. And so it's both. So all 500, and actually I think it's almost 600 now, are credentialed to provide telemedicine. There are times that I still don't have enough, and so I've had to hire some that are not in our system. I've hired on the coast, and I'm interviewing for psychiatrists right now. We actually just started a telepsychiatry program here for all of your students, February 1. So we provide through the clinic telepsychiatry to your students a couple days a week. So that service is one that's being replicated across the entire state, so it's got a demand that needs more. So we'll have dedicated people that's all they do. So I think we'll partner more and more throughout the state to use the physicians that are out here and just help them know how to utilize it for their own patients. And then it'll all come together eventually as a web of support. Yes?
How does FaceTime compare for telemedicine visits?
So glad you asked that question. So it's not HIPAA compliant, it's a violation. So is it being done? Yes. There are people all over the state that are taking pictures of a rash or an EKG and forwarding it to a doctor, and it's probably just fine. The problem is it's not HIPAA compliant, and it's a violation of privacy and security. So the quality you get is good. You do it all the time. Lots of people use FaceTime. I have a similar app on my phone that's for our telemedicine program. It looks just like it, but it's encrypted, it's firewalled, it's secure, and the privacy and security is compliant with HIPAA. So it looks the same, but it's not. So FaceTime and Skype are considered illegal from a medical diagnostic purposes. But it is being done.
Does this system only work with hospitals, state hospitals, or private institutions too?
Both. So of the 165, actually, as of now, it's 166. I've just got a text about that. So 166 sites, only 2 are part of UMC, Grenada and Lexington hospitals. The rest are not affiliated, have nothing to do with us, contracted with us for the service. Public, private, mental health centers, QHCs, all, you name it, schools, businesses, whatever.
And how they process like insurance? If you have like government insurance, private insurance, or Medicaid, like Medicaid would be easier because it's in the system. But I mean, if you have, now with the healthcare, all different source of how is for you a challenge like to adapt to the new healthcare system?
Yeah, so when we see a patient, all right, so in person, when you are treated, we do your record, medical record, and that is then coded and sent to your insurance company to be reimbursed. The same thing happens through telehealth, but there is a special code that says it's telehealth, and in Mississippi, they're mandated to pay for it at the same rate. So that hadn't been a rose garden, but the law's there. So they will reimburse, so I just submit the claim. The patient doesn't have to do anything different. Dave, did you have a question?
Yeah, so tell us a little bit about the regulations that you've related to physician extenders, nurse practitioners that you've had to fight to?
All right, so I don't know how familiar everybody is with nurse practitioner practice in the state, but medical board and nursing board, the nursing board regulates nurse practitioners. And they're required in Mississippi to have a collaborator, and the collaborator has to be within so many miles of where they're practicing. And so we went and worked with the medical board and nursing board to get a separate regulation written that said that that collaboration could be done through technology, so that the telehealth connection means now that they can be anywhere in the state and be immediately available. It's actually better collaboration than the rule that they have structured. So we just had to educate the medical board that this was actually a better level of care, even though they may be hundreds of miles apart. And we've gotten a new regulation written saying that that would be acceptable. So that was a big win.
Kristi, you've been using two terms, telehealth and telemedicine.
I'm
Can you
glad you
tell
asked
us?
that. Yeah, there's also e-health, mobile health, lots of terms. You'll hear all of those used interchangeably like I just did. For me, telehealth in the national definition is that's the big umbrella. Telemedicine is medical delivery of health specialty care consults. That also includes things like teleradiology, where there's an image that's sent and evaluated. So telemedicine is medical care through using technology from a distant site from your hub site. The rest of it is things like using the same network for education, research, workforce development. Telehealth is bigger. It has preventive health care as well as taking care of sick people with technology.
One more question. You're using telehealth technologies for other health-related sort of paraprofessional providers, dietitians, health educators? What's the future of that?
Yes, so everything we have, because that's expensive for people to give those ancillary services that are necessary, case management, medical coders, patient navigators, pharmacists, diabetic educators, nurses. We're using it for anything, therapist, psychologist. So any service that we have that somebody needs, we can provide. So I'll just say those are the main ones right now. There's more that are in the works. I mean, there's people wanting to have our legal team be available so that if there is our ethics team, so if there's an end-of-life decision for a patient, that if we have an ethics committee and board that evaluates, say somebody's at end of life and they're trying to decide if they should discontinue a feeding tube or a ventilator, that's a pretty serious decision. And in our hospital, it's a different way that that's evaluated in a small community hospital, but we can recreate it. So that's a good example. Dentistry is starting to do telehealth as well. So there's a lot of possibilities.
How would you handle a situation, a scenario with malpractice in the field?
And with a small practice?
Not malpractice. Is there like
okay.
it's gonna be a big network, so who's gonna be in charge of the final?
All right, so that's all still, every case is different, but in our network, because all of our providers, even the ones I've hired from somewhere else, I bring them on as a clinical affiliate of UMC, so they're protected under tort claims, and their malpractice is much different than a private practitioner. If I start going anywhere else, out of state, international, any of that, it's all a whole different ballgame. The malpractice would have to be purchased separately from our state Tort Claims Act. The model we have right now is very secure and solid from a malpractice standpoint, but when anybody's sued, they sue everybody that's touched any of this stuff. There's been some interesting cases international where the international was, the provider was international. And when it came down to the case, they washed their hands up and walked away, and the state was left with the whole burden of the payoff.
Don't want to cut off questions. What more we have other things that we'd like to get Dr. Henderson involved with? One more question? Let's all give her a hand.